Okay, so over the past few years, there's been a number of sort of national guidelines and updates to sepsis and sepsis criteria and sepsis management. We're all still trying to get to grips with the new criteria and what that looks like and what that means for us as clinicians. So we're all, I think, quite familiar with the idea of SIRS, so systemic inflammatory response syndrome, where you had 4 nice easy criteria around heart rate, blood pressure and respiratory rate that kind of gave you an initial feeling as potentially does this person have a systemic inflammatory response, and then if they had infection on top, we'd call that sepsis. We've moved on from there, and the NICE guideline that came out in 2016 was probably the main driver towards that. So it is a bit more comprehensive, there's more detail in it, it's a big document with lots of pages, and I think the challenge has been translating the very comprehensive NICE guideline into something that's workable for people who are reviewing patients on the ground who may be acutely unwell and need to make a decision about what to do. So in response to that, lots of trusts have moved towards an approach of sort of sepsis screening. So at NUH we have electronic observations which will automatically calculate whether potentially your patient could have sepsis and trigger for a review of that patient in terms of a sepsis review. So the new NICE guidelines have moved towards somebody having evidence of organ dysfunction and having an early warning score or a national early warning score of greater than 3. And it tries to put people in groups of severity, and really the severity is very closely linked to what is their risk of death. So it's about mortality and trying to manage the people with highest mortality quickly and effectively. So they've gone with red, amber and green. So those people who are in the red group have a high risk of death from sepsis, moderate for the amber group, and green is a low risk for the red group. We say if somebody's got an EWS or a national early warning score of 3 or more, plus they've got a proven or suspected site of infection, and that's really key because lots of people have an EWS of 3 for all sorts of physiological reasons that aren't related to infection. So that second piece is really, really important. Do they have a suspected infection? And then if they have a sign of organ dysfunction as well, from the list that as NICE has sort of produced and validated, then you can call them, they're in that high risk red category and they need to be managed urgently as a medical emergency for sepsis. So the signs of organ dysfunction are a new altered mental status, respiratory rate of greater than 25, or an oxygen requirement of more than 40% that's new to maintain SAT above 92, a heart rate of greater than 130, blood pressure of less than 90 systolic, or less than 40, so a 40 drops in their systolic from their normal baseline. So that is quite important, and perhaps the SIRS criteria didn't quite capture that, so people who are normally hypertensive and they drop by more than 40 in their systolic is a warning sign. Reduced urine output, so less than 5 mL per kg over the last 2 hours, a lactate above 2, and that's a serum lactate, and the presence of a mottled or non-blanching rash or sort of ashen appearance. So they're all the signs of the organ dysfunction. So you'll notice in there that temperature is not one of those. So that's kind of a key change, that we're moving away from using temperature as an indicator for sepsis. And the thinking behind that is temperature is probably a regulated response, and it may be a completely appropriate response to antibiotics, to infection. So we can consider that perhaps normal in the context of infection. However, it is worth bearing in mind that hypothermic patients, so those with low temperatures, you could consider that a warning sign as well. So if the patient meets the criteria for sepsis and you have a clinical suspicion or a proven infection somewhere, then it's about instituting the Sepsis 6 bundle. And the bundle is about rescuing that patient essentially, the urgent actions that you need to take. And the 6 things. So the first one is oxygen, so administering oxygen to maintain saturations above 92%, taking 2 sets of blood cultures and any other microbiological cultures that you can obtain in a timely way. So not withholding antibiotics whilst you're doing that, but to take the 2 sets of blood cultures, you obviously need to have IV access, and to administer antibiotics you need to do that. So 2 sets of cultures before antibiotics really are crucial, and I can mention a bit later about why 2 sets is important rather than just a single set. Taking a serum lactate, and monitoring fluids in and out, and giving an initial 500 ml fluid bolus if they are hypotensive, and monitoring the response to that. The 5th one is administering IV antibiotics, and ideally they should be source specific. So if on clinical examination or history or investigations there's a clear clinical focus, then following the trust guidelines on which antibiotic to use for that focus. If it's not clear what the focus is, then to follow the guidance for sepsis query source, so of an unknown origin. And that may be different in different trusts. Here we use tazocin for sepsis of unknown origin. But before administering antibiotics, you really do need to check for previous resistant organisms. So there's no point in administering tazocin to somebody if last week they had a tazocin resistant organism in their blood cultures. So the chance of that working is going to be very low. So the antibiotics are only effective if they're the right ones. So it's about choosing the right antibiotic. So having a quick look and seeing whether they're known to have resistant organisms, or are they at high risk of resistant organisms. So for example, they've recently finished a course of broad spectrum antibiotics that was stopped, and now they've become acutely unwell and septic again. And then the final one is considering an appropriate escalation to a critical care area, if suitable, and having a discussion with the consultant about sort of further management and escalation of that patient. So that's the sepsis 6 bundle, and the idea is that administering all of those together in a bundle will have improved outcomes in comparison to just doing 1 or 2 on an ad hoc basis. So the sepsis 6 bundle really is just the initial management. So hopefully you're recognising and rescuing those patients, but the next step really is how you're going to save that patient. So they're in dire straits, you've resuscitated them effectively. Well, now what? So they're on antibiotics, they may be having fluids, etc. What do we do next? So really this is our opportunity now they've stabilised to investigate and try and find the source of infection and manage that appropriately. So that might involve radiological investigation, so the obvious things like chest x-ray, but do they need a CT scan if the sepsis source is really very unclear, or there's a possibility of intra-abdominal infection, and any other radiology that may be appropriate depending on how the patient's presented, such as MRI spine or x-rays, etc. So secondly is around source control. So this really relates to when you have a focus of infection that needs some sort of removal or management in order for it to be effectively dealt with. And this is as important as the antibiotic therapy in a lot of conditions. So for example, if you discover a liver abscess or a blocked biliary tree, managing that sort of uncontrolled source of sepsis is just as important as the antibiotics, and actually will probably lead to sort of a better outcome for the patient if that's done early rather than later. So early escalation to surgical colleagues and discussion as to kind of ceilings of care and how appropriate it is to manage sort of invasively if there is a source of infection. And then sort of hopefully 24, 48, 72 hours down the line, you should have a patient who's stabilised from a sepsis perspective, and it's then time to review everything and start to make some antibiotic decisions. And there is sort of national expectations of how we should be reviewing antibiotics, and it is specifically for ST3s and above. So the person who performs the antibiotic review does need to be a senior member of the team, and that is the expectation. The trust is actually performance managed on how well this is done. So it's probably worth going through for a couple of minutes of what is the expectation of you to review the antibiotics. So Who does it need to be? So I said it needs to be an ST3 or above. And the reason behind that really is it's somebody who needs to have the skills but also the confidence to be able to make a decision about the antibiotics. So it's likely that somebody else probably will have started those antibiotics, potentially in A&E or out of hours, but it may be you who's the registrar on the ward reviewing them a couple of days later. So it needs to be somebody who has the skills and confidence to be able to not just start antibiotics, because that's probably the easiest step, but being able to stop or change antibiotics at that point. When should it happen? Well, we say around about 48 hours, but definitely by 72 hours. So that's really the national standard. All antibiotics should have a documented review by 72 hours. And by that point, we should have more information available. So the patient's condition will have either improved or deteriorated. Clinically, it may be more apparent where the source of infection is. We should have results of imaging, and we should also have some results back microbiologically as well. So results of blood cultures that may be negative or positive, and other cultures from other sites. So by 72 hours, all the information should be there to be able to make a decision about how the patient is doing and what the next steps need to be in terms of their therapy. And what should it consist of? So at NUH we use the acronym of the NICE outcome. So we want a nice outcome for our patients, so that's part of our review, and each letter stands for something. So N is for need, so we need to document the rationale, the evidence of infection. So why does this person need an antibiotic and what for, and what is our supporting evidence for that? So I is for IV to oral switch, so we're probably quite familiar with the criteria for when to switch IV to orals, but I'll just quickly go over them. So some clinical improvement in the patient, obviously the oral route being available and being reliable absorption, and also having an oral antibiotic available that's suitable for the patient. Their markers are improving, so their observations, temperature, white cells are all starting to move in the right direction. And then they haven't got a specific indication for prolonged therapy. For example, endocarditis is a suspicion, or they have an empyema that has yet been drained. So if that's not present, then documenting the IV to oral switch. And if you're unable to do that, then why not? So what is the need for IV antibiotics at that point? C is for culture and sensitivities. So reviewing and documenting results of any microbiology investigations, and actioning those if there is an action to be taken. And then E is for the end date. So having reviewed the patient and seen their clinical progress, where do we see the antibiotic course ending, and then documenting that. So the national criteria kind of give maybe 5 outcomes from this review. So you can either stop at that point, and that's one that often doesn't happen. So this, as I said, it's a lot easier to start than it is to stop, and sometimes at 48 or 72 hours it becomes apparent that maybe that deterioration and that EWS score was not related to infection, and investigations are negative. We might have found another cause for that acute deterioration, and it's okay to stop the antibiotics at that point. The idea of completing a course of antibiotics has really had its day. I think 10 or 20 years ago, this was the mantra that consultants were learning, that you must complete the course, you must complete the course. But if it was never infection, you don't need to complete the course, you can stop the antibiotics. You can escalate the antibiotics, so if they're really not responding, then perhaps that's the time to discuss with microbiology, actually, do we need to escalate to a different antibiotic? But alternatively, you might be able to de-escalate the antibiotics, so you might have a culture result that has a more sensitive pathogen in it. You can step down the antibiotic to something a narrower spectrum, so that would be moving from something, say perhaps tazocin, down to flucloxacillin because we've grown Staph aureus. IV to oral switch as an outcome, and then one that's often forgotten is OPAT, or outpatient antibiotic therapy. So if this is someone who's going to have the need for a longer course of antibiotics, starting to think about whether that can be delivered in a different setting to the acute hospital setting. And then for all of that, a new stop date or a new end date needs to be documented. So it's fairly comprehensive, and that criteria needs to be met in order for us to sort of be compliant with what we're expected to do nationally around antibiotics. So yes, we need to recognise and rescue those sick patients and get on and treat those people who you really cannot afford to wait and see with those high risk red sepsis. But 48, 72 hours down the line, you need to kind of review everything in the cold light of day and clearly document what the next steps are. So when you're initially reviewing the septic patient and deciding to start IV antibiotics, then obviously taking those cultures is really crucial, because that will allow the person who's reviewing a couple of days later to have as much information as possible. And I mentioned about why 2 sets of blood cultures is kind of more important than 1. So if you take 1 set of blood cultures, you will miss about 15 to 20% of bacteremias. If you take 2 sets, you'll probably detect between 90 and 92% of genuine bacteremias. So that's actually quite a big difference, and you're kind of going from about 75% sensitivity up to about 90% sensitivity. So that second set of blood cultures, and really it's that volume of blood, so those extra 20 mils of blood, really does help to improve the sensitivity of the test. So just taking those extra few seconds to fill up 2 more bottles will hopefully really get the diagnosis later down the line. And then the other thing that I think will really help people in terms of making the system run a little bit smoother is if you're unsure at the time when you're instituting the Sepsis 6 bundle and starting IV antibiotics, writing something along those lines around what your clinical impression is and the level of uncertainty. So if somebody's acutely unwell or deteriorating, yes, you need, the right thing to do is to start antibiotics and get the investigations and investigate appropriately. But quite often it's not documented in the notes kind of what the level of certainty was, or whether we felt it was actually quite unlikely that infection was driving it, but we had to start in the acutely unwell patient. So writing something along the lines of, even just what's the differential here, what are the alternative diagnoses, how strongly do I feel that this is infection, and where do I think that infection is, will really help either your colleagues or you down the line at 72 hours decide actually, can we stop at this point, or do we need to continue and continue to treat for infection. No, so there's actually no correlation between the spike in temperature and a bacteremia. So you don't need to wait for a temperature spike. So sometimes we do see that written in the notes, take blood cultures if patient spikes. Okay, that may indicate they have an infection, but if you think that the patient may have an infection or you're about to start IV antibiotics, then take the blood cultures beforehand.